What's up, Ninja Nerds? In this video today, we're going to be talking about dysphagia that includes oropharyngeal dysphagia and esophageal dysphagia. This is a part of our clinical medicine section. If you guys really do like these videos, they help you, they support your understanding, please support us. And you can do that by hitting that like button, you can comment down in the comment section, or you can subscribe. Another thing that I really urge just for your overall benefit, because I think it really will be crucial to your understanding of this topic, is if you go down the description box below, there's a link that goes to our website. On our website, we have amazing things that our team has really worked hard to develop, things like notes, illustrations, quiz questions, as well as we're even developing an exam prep course. So go check that out and really help yourself to understand these topics even more. Let's talk a little bit about now dysphagia. So what is dysphagia? So it's difficulty swallowing, but we have to take a little bit more of a detailed look at this. So when we talk about oropharyngeal dysphagia, it's really the difficulty in being able to initiate swallowing. So you know the process of swallowing we call deglutition. It really involves so many muscles. And whenever there is this difficulty in being able to initiate the swallowing process, this super suggests oropharyngeal dysphagia. So let's write that down. So it's difficulty initiating, and I think that really helps you to understand this. And I think oftentimes when you're going to your patients and you're asking them these things, I think this is the best way to kind of describe it to them. Like, are you having difficulty kind of initiating the swallowing process? That may help you. Another thing that I really think kind of sets apart oropharyngeal from esophageal dysphagia is ask them questions, because oftentimes there's a lot of these upper kind of muscles here, the pharyngeal muscles, the uvula, the soft palate. These not only help to initiate the swallowing process, but they're supposed to prevent like regurgitation. So sometimes if patients also complain of choking, or they feel like they're coughing a lot, or they're having a lot of like regurgitation up into the nose, that's super suggestive of oropharyngeal dysphagia, much more so than esophageal dysphagia. So really think about that, difficulty initiating the swallowing process, plus the combination of coughing, choking, and really big one, nasal regurgitation. That really suggests more specifically the oropharyngeal. So with oropharyngeal, it comes down to two particular things. One is the nerves that come from your brain and spinal cord that come to these muscles that help to contribute to the swallowing process. Something's wrong with these. So there's some type of neuromuscular dysfunction, or there's something that's impeding the actual lumen of the upper parts of your GIT. So again, it's some type of structural dysfunction, or it's a neuromuscular dysfunction. Let's now talk about those two things now. So if it's structural dysfunction, it has to be in the upper parts of the GIT. So here I have representing particularly the pharynx in red, and then here we come to the esophagus. So in order for this to be oropharyngeal, it can't involve the esophagus, it has to involve the pharynx. So what we use as the landmark is the upper esophageal sphincter of the esophagus. Right above that, what ends up kind of becoming a problem is in older individuals, they can develop a disease called a Zinker's diverticulum. And I think one of the big things here is that these are usually older patients, and they have very foul smelling breath. And the reason why is when food and fluids are usually coming down this way, right, to move through the pharynx into the esophagus, sometimes some of this food will move in here. And some of it will kind of get stuck, which will represent in kind of this brownish color here. Some of this food will kind of get stuck in here and kind of get metabolized. And this is why these patients oftentimes have very terrible foul-smelling odor to their breath. But this is one potential cause. So one of the reasons why these patients have difficulty swallowing is because of the Zinker's diverticulum. That would be the structural problem here. Another reason would be the nerves and muscles are injured. So maybe there's not anything structurally, it's something nerve muscle. So you have to know that your central nervous system has upper motor neurons and it has lower motor neurons that go to different parts of your body. And sometimes you even have cranial nerves that also go to particular muscles. So whenever you have some type of injury of any of these nerve structures, do you think you're going to get a really good pharyngeal contraction to help to move things along the pharynx and propel it into the esophagus. No. And so that usually was the problem here, is that the issue in this disease is that you're trying to move things from the pharynx into the esophagus, and it just isn't happening. So there is an inhibition, if you will, of propulsion. So you're inhibiting the propulsive action. And I think that's the best way of describing this pathology. So what are some of these particular CNS disorders that affect the nerves? Well, some of these, they can really be pretty variable. They're more chronic, and I think that's the important thing to remember. Usually it's things like ALS, so degeneration of the anterior motor neurons, or it could be Parkinson's, which is usually some type of destruction of the substantia nigra, and sometimes it could even be multiple sclerosis. And I think these are some of the more chronic diseases that you could see these particular types of factors. All right? But again, it's some type of nerve disorder. The other one is it often can be acutely and sometimes chronic. It could be a neuromuscular junction disorder. And we do see this at times in a disease called, we're going to abbreviate this one, myasthenia gravis. This is a neuromuscular junction disorder where they have antibodies that are attacking the acetylcholine receptors. But the same concept exists. It's that in this situation, it's the nerves. In this one, it's a problem where the reception of the signal at the muscles is impaired. Okay? So I think these are the big things that you have to be able to think about here. Is it some type of neuromuscular disorder, or is it a structural disorder? Oftentimes, these don't just cause problems with just dysphagia. You may have just weakness. You may have features of tremors. You may have optic neuritis, ophthalmoplasia types of features. With this one, you may have other muscles that are weak besides this one. You may also have diplopia due to weakness of some of the extraocular muscles. So there's not just one particular area, look for other ones that are affected. And if you see multiple types of nerves that could be affected, you're thinking more neuromuscular dysfunction. If you aren't really seeing that, then you're starting to think more about the Zinkers, especially in an older individual. Okay, let's come down now and talk about esophageal dysphagia. So with esophageal dysphagia, the issue with this one is it's not an issue with initiating swallowing. You can initiate it, so food will move easily from the pharynx into the esophagus. But it's getting it through the esophagus into the stomach that's the problem. So oftentimes with this one, it's kind of what patients usually describe as food is kind of getting stuck in their esophagus, but it's difficulty moving substance, we'll say put food or fluid through esophagus. And oftentimes they'll describe this as a sensation of food is getting stuck in their kind of throat, or in this case the esophagus though. And it's usually because something is impairing the movement through here. Maybe it's an actual obstruction, or maybe it's the nerves and the muscles that are involved in the wall of that esophagus aren't functioning correctly. So let's talk about those. If it's a structural dysfunction, there's a lot of different causes. All I'm doing is I'm taking a section of the esophagus here and I'm zooming in on it. What if I have a kind of like really narrow esophageal lumen? Maybe in this particular situation, it's super inflamed, really inflamed. You know there's a disease? It's called esophagitis. Esophagitis, you know there's so many different types. I'd say reflux esophagitis in the scenario of GERD is probably the most common, so look for patients who have heartburn. But it could also be pill-induced. It could also be eosinophilic, so look for patients who have histories of allergies. And then on top of that, it could be potentially infectious. Usually you're looking for that in a patient who has HIV, AIDS, or they're immunosuppressed. But I'd say out of these, esophagitis will definitely be one thing that it's going to cause inflammation, and it's going to make it hard to move things through this tiny little hole. Okay? Another one is, especially with reflux, esophagitis can cause these things called strictures, which is like fibrosis. So now just add a little bit of fibrous tissue here. around this, and again, you kind of have like an inflamed or fibrotic area there, it's going to narrow the lumen, it's going to interfere with the normal movement of substances through the esophagus. So those are two things that I would want you guys to remember, something that's super narrowing that esophagus. Another one is we see this in the upper esophagus. So I would really want you to remember that this is more in upper esophagus. And this is usually something where patients have like this weird like web. It kind of like protrudes in only on one side. So imagine it kind of like a shelf, and it protrudes in only on kind of like one side. It doesn't completely circumferentially kind of occlude the actual lumen of the esophagus. It kind of just butts in out of one side. And usually this is what we call an esophageal web. We call this an esophageal web. Usually this one can be associated with iron deficiency anemia, and it can also be associated with like inflammation of the tongue. They call this disease Plummer-Vinson syndrome. And so oftentimes you may see that terminology of Plummer-Vinson syndrome where patients have iron deficiency anemia, glossitis, and an esophageal web. So they're having dysphagia. So these are things that I want you to think about with that one. The next one is it is circumferential. So you have a ring, if you will, a very thin kind of shelf, and it protrudes in to the entire lumen and circumferentially occludes that lumen. What is this one called? Big thing to remember is that this is primarily in the lower esophagus. This one is a ring. And so we call this an esophageal ring. They also call this Schatzki's ring. This one is usually associated with GERD. So sometimes in patients who have GERD, you can get a lot of reflux, you can cause esophagitis, but sometimes you create this circumferential ring that occludes the lumen. So in this one, we're occluding the lumen. In this one, we're occluding the lumen. This one, we're occluding the lumen. Okay, it's just in different scenarios. Look for patients who have history of reflux or strictures because of their reflux, usually benign strictures. It could be malignant. Look for history of Plummer-Vinson syndrome. Look for anything that makes you think about Schatzki's rings. Okay, usually lower esophagus. The last one is you have a tumor, and this is probably a really sad one, but if you have some type of neoplasia that's kind of protruding into the lumen here, that would also be a big one. So if I see some type of like vascular type of like mass here, that would definitely be a trigger. So think about esophageal cancer. Okay. And this could be in the form of cancer or malignant strictures. But either way, in this concept here, these are occluding the lumen. Usually with this one, you would see other features, potentially GI bleeding, nausea, vomiting, anorexia, weight loss. So you'll see other features that suggest more of a cancer presentation as compared to a lot of these. But it can be difficult at times. So if it's not structural, the next thing that you have to think about is could it be neuromuscular or functional? And so with this one, this is usually a nerve or muscle disorder. And there is a bunch of nerves that actually kind of supply the muscle here. It's called the myenteric plexus. I'll represent this in kind of this purplish maroonish color. There's a disease called achalasia. And in achalasia, the problem with this disease is that these nerves aren't working very well. Okay, there's decreased function of this myenteric plexus. And what happens is these patients, they have a very high lower esophageal sphincter tone because these myenteric plexus are supposed to kind of relax that. It doesn't. And they have decreased contraction of the mid-distal esophagus, right? So decreased contractility of esophagus, but they can't relax their lower esophageal sphincter. And so the pressure there is really high. And oftentimes, when you look at this under imaging, it shows that classic bird's beak type of appearance. That's one really big thing. So achalasia could be one. These patients will have dysphagia. The other one, though, is going to be causes an intense chest pain usually. So this one's usually causes an intense retrosternal chest pain, and it's called esophageal spasm. Sometimes they even call it diffuse esophageal spasm because it really does affect the entire esophagus in this sense. But what happens here is it's not to do with the nerves, it's the muscles. The muscles, for some weird reason, create this kind of like rhythmic but irregular high amplitude contractions. So the muscle will just go ham, and it'll really cause the contractility of the esophagus to be disorganized and just really funky, and it won't be synchronized. And so what you'll see is you'll see multiple areas of peristalsis occurring here, but not in a syncytial type of manner, because it's supposed to be contract, relax, contract, relax. Here you have a bunch of different areas contracting at the same time. One thing to remember is that it doesn't really affect the lower esophageal sphincter, so that pressure there is usually kind of like normal. And so when you get a chest x-ray on this one, a barium swallow on this one, oftentimes these patients have like this weird type of corkscrew pattern on their actual barium esophagram. The last one is called scleroderma, and this one's kind of interesting in the sense that it's just usually the muscle is becoming fibrotic. So all this muscle tissue is kind of atrophying, and you're having lots and lots of fibrosis due to autoimmune disease. So you're having destruction of the actual smooth muscle, and then tons of fibrosis that is occurring of this actual tissue here. And so what these patients usually experience is really low contractility and low esophageal sphincter pressure, right? So they have low contractility of esophagus, and their lower esophageal sphincter pressure is relatively low. And I think this is really important to remember. For this one, it's usually kind of look for other features. So this one, intense chest pain. This one, usually not super obvious, except if you get that kind of barium swallow. For this one, you're usually looking for that classic CREST syndrome, so calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, so they have weird hands, and then telangiectasia, some of those skin manifestations. And so I think that's a big thing to look out for as kind of a cue to think about scleroderma. But at this point now, we have a patient, they come in, they're saying, man, I'm having difficulty being able to initiate swallowing, coughing, choking, regurgitation, or oropharyngeal. If they say, I'm having difficulty, we're kind of getting the food through my esophagus, it feels like it gets stuck somewhere, esophageal. Then think, is it structural? Is it an obstruction like a Zinker's? Or is it strictures, webs, rings, cancer? Or is it neuromuscular? Is it ALS, Parkinson's? Is it a stroke that they had in the past? Is it myasthenia gravis? Or is it neuromuscular for esophageal? Is it achalasia? Are they having terrible chest pain? They get esophageal spasm. Do they have any CREST findings? Think about scleroderma. All right, now that we've talked about dysphagia pretty decently, let's now go into how do we diagnose dysphagia. So first thing, is it difficulty initiating swallowing? If it is, that's likely oropharyngeal. And then I just got to think, it's either structural or functional. Well, structural, usually one of the best tests that's easy, it's non-invasive, is a barium swallow. And what they'll do is you have the patient chug some barium, and it's really kind of like highlights on x-rays. So you'll have them do that, and if it's abnormal, it's probably a structural cause, meaning I filled a little defect, a little kind of like pocket. So it's probably a Zinker's diverticulum, and if you see here on this barium swallow, here's the filling of that contrast into that little Zinker's, and that would tell you that's likely their cause. If it's normal, it really doesn't, again, exclude the fact that it's not a neuro problem. And so from here we say, okay, it definitely could be a neuromuscular disease. I got to do a full neuromuscular workup. Do they have a stroke? Do they have a history of Parkinson's disease? Do they have a history of ALS? Or do I need to work them up for myasthenia? That's a little bit more of an in-depth discussion that we won't kind of talk about here. The next one is if a patient has sensation of food getting stuck. That really fits more of the gambit of esophageal dysphagia. Again, it's not a bad thing to obtain a barium swallow. I just think it's important to remember that it's not going to be very specific. It may help you to see that there's kind of a narrowing of parts of the esophagus, which could tell you, hey, there's probably some type of like structural cause, but it won't tell you the exact type of structural cause. And I think that's important to remember. So we're still kind of left after that doing it saying, still could be a structural or neuromuscular cause. There is some things that we'll highlight that we'll talk about a little bit more, for example, in the esophagitis lecture and in the esophageal motility disorders lecture. But for right now, what I want you to trust is that when a patient has a really significant esophageal dysphagia, one of the kind of perfect tests to go to here is an EGD.
So this is kind of like a esophageal-gastroduodenoscopy, and you're basically looking at the esophagus, the stomach, and the duodenum. But in this case, you're really just looking at the esophagus. And you get a good visualization of it. And if it's abnormal, then we can kind of say, oh, what is it? If I can visualize these kind of anomalies, I can say, oh, look at that. There's a complete circumferential ring here. And this is usually at the lower esophagus. This is probably a Schatzki's ring. All right, beautiful. That's likely the diagnosis. Oh, I see this incomplete or kind of asymmetric kind of shelf popping out from the upper part of the esophagus. Oh, that's probably esophageal web. Correlated if they have Plummer-Vincent syndrome as well. Esophageal cancer, you'll be able to see a pretty nasty neoplastic mass. We'll talk about that in the cancers lectures. And then esophagitis, we'll talk about that more in the actual lecture itself because there's different forms of esophagitis that we should have an idea of what those types of esophagitis pictures look like. But you'll be able to see pretty significantly the esophagitis. Now, for most part, usually you do an EGD to rule out things like cancer and then to include is it these types of diagnoses here. If it's normal, it doesn't mean that there isn't a neuromuscular cause. And so usually what we do is for the gold standard of esophageal motility disorders is you do manometry. You take a probe, you put it down the esophagus, and you measure the pressures in the esophagus. And it's really cool. We'll talk about it more in the esophageal motility lecture, but it will really help you to identify the neuromuscular cause. It is the gold standard because it'll show achalasia has poor motility in the mid-distal esophagus and high lower esophageal sphincter tone. The next one that I want you guys to remember here is scleroderma. Scleroderma, we'll talk about a little bit more in the esophageal motility disorders, but usually there's really not a good contraction of their mid-distal esophagus. So they'll have low amplitude waves there, and then their lower esophageal sphincter is also pretty weak, so you have low amplitude waves there. And the last one is diffuse esophageal spasm, intense contraction, high amplitude waves that you'll be able to see in their mid-distal esophagus, whereas their tone in the lower esophageal sphincter is relatively normal. And that'll really help to kind of outline the causes of dysphagia, especially the esophageal type. All right, my friends, so I hope that you guys enjoyed this lecture. Thank you guys for everything. Thank you guys for watching these videos. And as always, until next time.